good afternoon, everyone. This is Takwam Taruna with Association of State and Territorial Health Officials. Thank you all for joining us on this webinar focusing on the Alzheimer's Association Needs Assessment Toolkit. This webinar will provide an overview of the toolkit as well as highlight needs assessments that were conducted by states. If you have any difficulties throughout the webinar, please don't hesitate to email me at the email address provided on the screen. A quick note on webinar logistics. All phone lines for participants have been muted during this webinar. If you have a question, please post it to the chat box on your screen at any time through the course of the webinar. These questions will be used during the Q&A section following today's presentation. As you can see, we have a full agenda and an excellent panel of experts lined up to speak on this webinar. And so we'll go ahead and get started. Joining us first on today's webinar is Molly French. Molly serves as the Director of Public Health for the Alzheimer's Association. She works closely with the association's national and state partners to implement the Healthy Brain Initiative's public health roadmap. Prior to this, she partnered with national nonprofits to advance population health and also directed policy research for Partnerships for Prevention. Molly graduated with a Master of Science in Community and Regional Planning from the University of Texas and earned a Bachelor of Arts from Drake University. So without further ado, I will turn it over to you, Molly.
Yes, thank you. And thank you so much, ASTHO, for hosting this webinar and enabling us to feature our new tool for public health agencies to use in assessing at a population level the needs of people affected by Alzheimer's disease. For those of you who are a little less familiar, Alzheimer's is a rising public health challenge that places a major burden on people affected by Alzheimer's as well as caregivers and the communities at large. Currently about 5 million people, over 5 million people are living with Alzheimer's, and by the year 2050, that number we expect to nearly triple to almost 14 million people. Dementia is also one of the most expensive conditions in the United States. In 2017, Medicaid is expected to pay for nearly $44 billion on care for Alzheimer's and other dementias. And certainly as the number of people who are affected by Alzheimer's and other dementias rises, we expect those costs to continue rising in lockstep. From the 2015 Behavioral Risk Factor Surveillance System data from 33 states and D.C., we know that 1 in 9 adults age 45 and older are reporting memory problems that have been getting worse over the last year. And so that's what we are calling subjective cognitive decline. So when you hear me refer to that, it means the worsening memory problems. And these memory problems are substantial enough that 2 in 5 of people with SCD are saying that they are having to give up household chores. So things that they've been doing most of their lives, they're starting to have trouble with. And 1 in 3 say they need assistance because of the memory problems. CDC's crosstab analysis with the BRFSS data tells us that a large majority of people with subjective cognitive decline have other chronic conditions, and certainly those memory problems would complicate chronic disease management. Public health agencies and public health professionals certainly are very familiar and understand the importance of addressing any new or emerging public health issue by starting with the needs assessment and then using those findings to pull in and inform state policy programs and plans. And certainly as it relates to needs assessments relating to Alzheimer's and other dementias, those findings and results are very important. As my fellow speakers you'll be hearing from, to inform state plans on Alzheimer's, as well as other state public health plans, such as on chronic disease and injury. The use of data from the BRFSS and other data sources are one recommended action in the Healthy Brain Initiative Public Health Roadmap to increase public health programming, planning, and policy on Alzheimer's disease and other dementias as a public health issue. So let's say it's 5 minutes from, or maybe 5 minutes before today's webinar, and you get a call from your state health official office saying, we need you to do a comprehensive needs assessment on Alzheimer's and other dementias for our state plan. Now, you've done needs assessments before on many other important public health issues, but not on Alzheimer's, and you may even be wondering just why is Alzheimer's a public health issue. So some of your initial questions might be, how big of a problem is Alzheimer's in our state? Are there issues that the assessment should cover? What are they? Where do I go for information? Who can help me? And how do I even get started? So the good news is that there are data available as well as partners who can help. And now we've developed a toolkit to help guide you through that process and answer these basic questions. The toolkit certainly starts from a base of recognizing that public health agencies have a lot of existing expertise with comprehensive needs assessments, but tend to not be familiar with cognition and caregiving as public health issues. So we aim to provide a flexible but one-stop place to help you provide that needs assessment report to your state health official in an effective and efficient manner as possible. The toolkit suggests key questions, provides some best practices gleaned from states like Arizona and North Carolina, and provides much more. We developed this toolkit in partnership with CMT Consulting, and that team analyzed existing resources. They consulted with experts, including Dr. Nayar and also the North Carolina Institute of Medicine, and we obtained a variety of reviews by different public health professionals to try and provide a toolkit that would be the most helpful as possible. The toolkit, won't go blow by blow through its contents, but it is organized around generally the 6 steps that are involved in a comprehensive needs assessment. And then we tailored the information in those different steps, to give you information that's specific or tools to Alzheimer's and other dementias. So, for example, often the first step in a needs assessment process would be developing the partnerships to help support that. And so we provide suggestions for key stakeholders that you could involve and provide a matrix to help you in that process. Or when it gets time to collect data, then the toolkit has information about potential data sources on different issues such as disparities, mortality, caregivers. We also encourage qualitative data and make suggestions about how to get input from people living with the disease with Alzheimer's and their care partners. And while the toolkit gives you a step-by-step, goes through the needs assessment process step-by-step, it is entirely adaptable and flexible. So you can, if you're doing a smaller scale, more focused assessment, it can provide that support, or if you're doing anywhere from there to along the lines of a comprehensive assessment. So just to give you a sense of the resources that are in the toolkit, besides the matrix to help you with a stakeholder analysis, we have a list of data sources. There's different templates to help you with planning or with developing a press release checklist, a lot of pragmatic tools, and they are available in Word, so you can just pull, you don't have to recreate them, you just plug them in and get going. The toolkit is free and readily available on our Alzheimer's Public Health Resource Center at this URL. Thank you.
Thank you so much, Molly, for your presentation. Our next presenter is Michelle Rice. Rice is a project director at the North Carolina Institute of Medicine. In this role, she serves as project manager, researcher, and primary author for multiple simultaneous research initiatives and statewide health and policy stakeholder groups. Recent projects include healthcare analytics and dementia-capable North Carolina Task Force on Alzheimer's disease and related dementia. Prior to her work at the North Carolina Institute of Medicine, Rice also worked as a senior program associate in the International Health Policy and Innovation Program at the Commonwealth Fund. Previously, she also completed the Health Research Training Program at the New York City Department of Health and Mental Hygiene, Office of Health Media and Marketing, where she was responsible for managing the internal development of citywide health media campaigns on various health issues. She earned a Bachelor of Arts in Dramatic Arts and Anthropology at the University of North Carolina and a Master's in Public Health from Columbia University's Mailman School of Public Health. Michelle, the floor is yours.
Great, thank you. Can everybody hear me?
Yes, everyone is probably muted, but I believe they will be able.
Excellent. And I just want to apologize. I have a bit of a summer cold, so if I have to cough in the middle of the presentation, please excuse me, and I will return as soon as I can. So thank you for having me today. I'm trying to click to the next slide. I don't see, do I just, oh, double click. Gotcha. I was, as it said in my bio, I was the project director for the development of our state plan for Alzheimer's disease and related dementia. The title of the state plan that we released in March 2016 was Dementia Capable North Carolina. And just a little bit about the North Carolina Institute of Medicine by way of how we came to do this work. We were chartered by the General Assembly here in North Carolina in 1983, and we basically do a variety of projects looking at health and health policy issues in the state. And a lot of the format of our work is pulling together, mostly in the form of task forces, multi-stakeholder groups to look at an issue and to make recommendations to state stakeholders around gaps in that issue, and around things that are needed in our state around the various issues. So this, the Alzheimer's work came to us. There was some legislation out of our General Assembly for the state through the Division of Aging and Adult Services in our Department of Health here to develop a strategic plan for Alzheimer's disease and related dementia. I think at the time of the legislation, we were the 42nd state, I believe, to be putting together a state plan. So we were a little bit late in the game, but the bright side to that was that we were able to look at what a lot of the other states had already done by way of informing our work, which was nice. Unfortunately, the legislation came with no funding for it, so we sort of hit the streets a little bit in terms of trying to identify some funding partners for the work as well. So we developed the state plan in partnership with the Division of Aging and with some additional funding from the Duke Endowment, the Winston-Salem Foundation, AARP North Carolina, Leading Age, Alzheimer's NC, and the North Carolina chapters of the Alzheimer's Association. So basically what we did is we started our needs assessment process really by identifying several steering committee members who would serve as experts in driving our content, in helping us identify who the proper stakeholders were going to be in the process. We really tried to pull not only from various content expertise, but also from geographic diversity around the state as well, particularly when we're looking at issues around access to care and access to services like we found were so important in looking at dementia across the state. We wanted to make sure we had a pretty good cross-section of representatives from urban areas and rural areas who could speak to the different challenges in those types of settings as well. So we had about 47 task force and steering committee members, and those spanned physicians, researchers, service providers, family and caregiver representatives, and legislators. And basically, we looked at I've got it on a slide a little farther down. In the legislation that I mentioned, the bill named 16 different topics that we were required to look at. So we pretty much had our work structured for us already by looking at this, and that was a pretty comprehensive set of topics that we felt like we needed to look at. And what we did according to each of these categories is then we also looked at some different frameworks for how to structure that as well. And around the same time that we were beginning the work in summer of 2015, at the federal level was the announcement and launch of Dementia Friendly America. So we were able to look at their 5 primary categories and subject goals and put our 16 mandated categories within these goals. So that's sort of how we framed how we were going to look at the work. So I'm going to jump back a few slides. We really looked at, as we were talking about through the needs assessment toolkit, we started by looking at prevalence, and we looked at it both federally and at the North Carolina state level as well. We looked at not only the current levels of individuals with dementia or Alzheimer's disease, but we looked at the projected levels as well. Looking at the aging of our population, and also we looked a lot at issues around caregiver numbers and the changes in the demographics there. We looked at how in North Carolina in 2010 there were approximately 8 individuals between the ages of 45 and 64 who could be considered caregivers for individuals 80 or older, but by 2030 that number will be basically cut in half to under 4 individuals aged 45 to 64 for every person 80 or older, and started really examining the impact of what that was going to mean for our state. So as I said, we divided our categories into these 5 to frame the plan, and we started looking at the various issues within these categories. So in the first one, to raise awareness about dementia and transforming attitudes, we looked at questions of stigma, around family education, around the incorporation of messages around brain health into other public health messaging. We sort of used the frame of what's good for your body is good for your mind, encouraging not only specific dementia-focused initiatives, but also pulling messages about brain health into messages around cardiovascular disease, around diabetes, around other public health issues that were already being talked about pretty widely in the state. We talked about early screening, family planning, and community engagement. And so in this category, we came up with several recommendations. And I'm not going to talk through all of these very thoroughly. I can also, I don't know if y'all were provided a link to our full report, but for each of these recommendations, when we wrote these up, we did a lot of background and context for why the task force felt like this was an important area of need, and why it rose to the level of a recommendation in the report. The report also for each of the recommendations has not only that context setting and the specific ask of the recommendation, but it also lists at least one, but in most cases several stakeholders for whom this recommendation is relevant. And that's sort of the way that we end up tracking progress on the recommendation, by being able to go back to those stakeholders and ask them what has been going on in that area. So again, in this category around raising awareness, this was around increasing awareness and education, enhancing training for healthcare providers, creating a partnership to develop dementia-capable pilot communities, and establishing statewide coordinated leadership to oversee the implementation of the plan. For the second category, which was having supportive options that foster quality of life, we looked at a lot of the information around costs of long-term care and access to long-term care, and the understanding about the differences in the types of care facilities and the types of services that are available for families and individuals with Alzheimer's disease. We looked at, like I said, the median annual cost for nursing home care, and the ways in which we were hearing from caregivers about the difficulties in navigating the different types of care and identifying the resources to go to help with that. So there we go. The recommendations in this area were around promoting appropriate care settings, examining methods of reimbursement and incentives around new models of care, assessing the capacity in the health system for people with Alzheimer's disease and related dementia, improving telehealth, increasing access to services by improving transportation services, applying principles of person-centered care, and improving quality of care and care coordination through improved rating systems that included dementia-specific indicators and recommendations around measurement. Also in this category, we had recommendations around improving care coordination, expanding the dementia-friendly hospital initiative, promoting dementia-specific training for health professionals and other community workers, incentivizing entry into geriatrics and gerontology, and increasing compensation based on dementia-specific training and certification. So the next category that we looked at was around supporting caregivers and families. And again, I talked through some of this data and statistics that we looked at here around the caregiver ratios. We also looked at the status of the wait lists for our home and community-based services and the gaps in those types of services. We looked at issues that caregivers face when navigating logistical and financial challenges when they have a family member with dementia, and also at the increased risk for caregivers for declining personal health and for mental health issues such as stress and depression. The recommendations that we developed in this category were around promoting integration and accessibility of resources, ensuring adequate funding for specific services, especially for respite for caregivers. We made a recommendation around increased collaboration with North Carolina 211, which had just started in our state around the same time that we were putting together the state plan, and on enhancing employer policies to support family caregivers. Additional recommendations in this area were around looking at the outcomes and impact of home and community-based services programs, specifically around the cost savings in delaying institutionalization that can happen when families are able to access community-based and home-based services rather than going into long-term care facilities. We had a recommendation around expanding the Medicaid home and community-based services waiver program, and also around implementing best practices for the integration and coordination of the services. So in our next category, under the Dementia Friendly America framework, this was around promoting meaningful participation in community life. And this was the category that we put our recommendations that were around legal protections, questions around fraud, abuse, financial issues, guardianship. These all fell in this category. So our recommendations here were around awareness of legal protections, not only for individuals and families, but also for health, legal, and financial professionals, around understanding the specific issues that may pertain to individuals with dementia. Examining state statutes to determine if the legal protections are adequate, integrating fraud and abuse data across the state to improve services, and then also around improving home safety resources and enhancing public safety and law enforcement outreach, specifically around dementia. And then in the final category in the dementia-friendly framework, we had reaching those who are underserved and enhancing data collection. So for this category, we looked at a lot of the prevalence data around dementia and looked at the disparities across race and ethnicity groups, and also the higher rates among for individuals with intellectual and developmental disabilities. We also identified some gaps in death certificate data and the reporting of deaths related to dementia. We also identified a few areas of need in terms of expanded participation in clinical trials. So this led to our recommendations around the establishment of a statewide collaborative registry for individuals both with dementia and individuals who do not have dementia for preventive research as well. We talked about including periodic inclusion of the cognitive impairment module of the BRFSS data, improving prevalence data through death certificate completion, and improving data collection through the implementation of a statewide data reporting system. So we had a lot of ground to cover in about a year and a half, and you know, like I said, we were able to sort it through an existing framework, which was very helpful. But we went through a lot of those questions about who are the stakeholders who need to be at the table, what are the things that we need to look at by way of data, who are the people that we need to talk to have a better sense of the different status of these types of services in various areas of the state. Since we published our report in March of 2016 and presented it to the General Assembly, there has been quite a bit of action actually on several of the recommendations, which has been fantastic to see. So I've got some updates here. In 2016, there were 4 different legislative actions on our recommendations. So the first was on establishing a dementia services coordinator through the Division of Aging, and that is actually now Mark Hensley, who was consulted in the development of the Needs Assessment Toolkit. So he is now, his primary job is tasked with implementing the recommendations from this state plan. The last bullet point on this slide here talks about the statewide Alzheimer's coalition that was established, and so that is something that has come from Mark. And so they're tracking all of the recommendations. They're developing working groups to prioritize which ones are short-term priorities versus long-term priorities. So that's really key in terms of being able to make sure that there's action on these recommendations. Also from the General Assembly, there was $100,000 funded for a dedicated 211 coordinator who also is based in the Division of Aging, and she, her role is to ensure that all of the information and resources that are in 211 that are related to dementia-specific resources is up to date, is accurate, that they have somebody that they can talk to make sure that they've got the most up-to-date information. There was also $1.5 million funded for 320 additional CAP-DA slots for the Medicaid Home and Community-Based Services waiver that came as a result of our task force as well. Uniform guardianship was enacted, and in the current legislative session there is pending legislation on the establishment of the Dementia Registry and on the establishment of the Virtual Resource Center. So we've been very pleased to see a lot of that action, and a lot of the stakeholders who were involved in the task force have continued to be involved in the working with legislators and working with state agencies and really statewide on overseeing implementation of the recommendations. So for more information, you can contact myself or, as I mentioned, Mark Hensley, who is now the director of the Alzheimer's Coalition at the Division of Aging. Thank you very much.
Thank you so much, Michelle, for the very informative presentation. We really do appreciate it. And next, I would like to introduce Dr. Bhagwat Nayar. Dr. Nayar is the Director of Healthy Aging at the Arizona Department of Health Services. In this role, he serves as the chairman of both the Arizona Falls Prevention Coalition and the Arizona Attorney General's Healthcare Committee. He also serves as an advisor liaison for the Governor's Advisory Council on Aging, as well as the Arizona Alzheimer's Task Force. Additionally, Dr. Nayar also holds an appointment as a clinical associate professor at the University of Arizona's College of Medicine. With over 16 years of health systems leadership experience, he has dedicated his professional career to population health and health systems improvement, public health, and teaching the future workforce. Dr. Nayar has led interprofessional teams to performance through strategic thinking, innovation, and proven business models. He is credentialed with added qualifications in forensic medicine and medical investigation, pain management, behavioral, and addiction medicine. And now I would like to turn it over to you, Dr. Nayar. Dr. Nayar, we're unable to hear you right now. In case you're unmuted, please feel free to unmute your line.
Good afternoon. Can you hear me now?
Yes, we can. Thank you.
Okay, thank you. Well, as I said, I was going on and on talking while I was on mute. I apologize. Good afternoon, everyone. As I said, thank you for that warm and wonderful introduction. I do need to make a correction in that I have a doctorate in naturopathic medicine, so the N was omitted on my credentials, but thank you for the honorary MD degree. And I would like to also thank ASTHO and the Alzheimer's Association for this opportunity. So today I would like to first start with a quote from the Institute of Medicine that appeared in their publication, 2015 publication on cognitive aging. Knowing is not enough, we must apply. Willing is not enough, we must do. And that really informs everything that we do at the Arizona Department of Health Services Bureau of Tobacco Chronic Disease, where where the Healthy Aging Program is housed. And also, there was a quote that is from Sharon Moffatt that says, we must capitalize on state efforts to coordinate public health chronic disease programs and include cognitive health in that larger picture. So that really resonates to what we do. On the next slide, I would like to share with you that the Alzheimer's public health needs assessment and the toolkit was really used with a back of the envelope approach, if you will, in that we had already created our state Alzheimer's plan, and that Alzheimer's plan is available if you are interested in it. You can look at it or even download it in PDF at azhealthyaging.com under reports and statistics. Our state plan was, of course, based on and informed by the Healthy Brain Initiative Roadmap through the CDC. And then what we did was we went back and looked at the needs assessment developed by the Alzheimer's Association, and my esteemed colleague Molly already went over the 6 steps that was framed around the following of a series of the 6 steps designed to help state plans and conduct needs assessments. And we did develop SMART goals and objectives. In fact, these 6 steps to develop or to conduct needs assessments, community needs assessments, in my experience, has been a dynamic and fluid process. So each of these steps, we can go back and forth, and our state plan is developed by the Alzheimer's Task Force, as an Alzheimer's Task Force, does include all these components where we are talking about a dementia-capable system, including early identification, the community services, research, treatments, the workforce development, public safety, and law enforcement outreach, as my other esteemed colleagues have already mentioned. So what we determined early on was that without our community partners and our limited dollars, we would really be swimming upstream. And the needs assessment and the toolkit, of course, clearly help with assessing the community needs, and talks about partnerships as shown in those 6 steps in the previous slide. So there's an African proverb that says, if you want to go fast, go alone. If you want to go far, go together. And given that our resources would be sort of like spitting in the ocean, as Wayne Tormel, our bureau chief, often states, with research, we were looking at where can we, as the Department of Health, make the most impact and be able to scale a program that would have a statewide impact. So to do that, we commissioned the University of Colorado and Denver to conduct a social network analysis to develop our protocols and support for joint services delivery. Some of the questions that were asked through that assessment were what kinds of activities are members engaged in with their partners, how closely are partners working together in their different relationships, what services to caregivers for people living with Alzheimer's disease and related dementias, which I will refer to as ADRD from here on, do partners provide, and what is the impact of different partnerships. And in terms of our focus with caregivers, which we feel that that's where we can make the most impact, given the challenges that all caregivers are experiencing, the fact that we need more and more caregivers in Arizona. And just to share with you some of the pictures, well, I'll be referring to how many people have Alzheimer's disease and related dementias, ADRD in Arizona, and what the caregivers' needs are, and that picture in my slides that are coming up. So we looked at the potential service gaps, and advice on future investment for caregiver support, and then we came up with some core recommendations that I will share with you. So some of the challenges that we have identified, of course, are uneven distribution of services and care coordination, lack of coordination of services and integration of services, and then especially the at-risk population. So we have identified that we need to make sure and be cognizant of the needs of disparate populations, people with developmental disabilities, people with autism who are at risk for developing ADRD if they live long enough, and American Indian, Alaska Native populations, African Americans, Hispanic Americans in Arizona. So given that, again, I would like to emphasize, as we all know, and I'm preaching to choir here, health is often unevenly distributed across socioeconomic status, and that we know health problems increase vulnerability to those people who are underserved, as well as people with developmental disabilities, whom often we tend not to have them on our radar, and we need to be more cognizant of the people with special needs, as well as people in the rural communities and people with the LGBTQ population. For example, in Arizona, we know we have about 43,000 people older adults who have both hearing and visual impairment. So that's another group with special needs. So some of the undetected needs and challenges are, again, some of the person-centered care for people with developmental disabilities. And I realize that I'm repeating this ad nauseum, but I think we cannot overemphasize the needs of these special groups. Aging adults with Down syndrome and people with intellectual disabilities. Of course, our need for workforce development and a capable workforce that can address the needs of these special populations. So now I'm having some network connection issues. Let me see. Okay, so it was resolved. I hope everybody can see the advanced slide. So in Arizona, we used the behavioral risk factor surveillance system, optional question under the cognitive module, and we know that about basically compared to national data, Arizona shows, as you see, people 65 years and older, we are about 12.6% who are reporting that they have some cognitive memory confusion loss, and over a 12-month period, and this is based on the 2015 BERFIS, compared to 12.1. So we're slightly higher than the national average across the ages based on that survey. And the mortality rate due to AD based on a 5-year trend, as you can see on this slide, has, although it plateaued for up to 2015, we had a spike between 2014 and 2015. We currently have about 150,000 diagnosed cases of Alzheimer's, ADRD, and we know that statistically this is only based on half of the people who are diagnosed. About 45-50% of people go undiagnosed and undetected. And I think those of you who are on the phone probably know that there are various reasons and challenges that lead to the undiagnosed portion of our population. Alzheimer's disease is the 4th leading cause of death in Arizona among the top 5 chronic diseases, and it's the 3rd leading cause of death among women 65 years and older. Currently, we have about 300,000 plus, and I say plus to qualify that. The Alzheimer's Association report, latest report, shows 300,000 unpaid caregivers, and the AARP Arizona report showed that we had 400,000 unpaid caregivers. So we see that this is a growing need in Arizona as it is across the country. And what we do to address the needs of ADRD population, and of course our focus is on caregivers, is we're looking at leveraging our Proposition 303, which is based on tobacco tax revenue. A portion of that can be allocated for the top 4 leading chronic diseases that cause mortality. And this is based on the determination by Center for Disease Control. So currently that translates to about $3 million per year, but that's spread across the top 4 leading causes of death due to chronic conditions in Arizona. So with the Healthy Aging Plan, and I have provided the link underneath the middle leg of the stool. We call it the 3-legged stool. The Healthy Aging is focused on Alzheimer's disease related services, as well as falls prevention and chronic disease self-management. And we all know that all of those are somehow interwoven and related to Alzheimer's disease and vice versa. We know that people with, for example, with ADRD are at a much greater risk for falls-related injuries and unintentional falls-related injuries. We know that people with ADRD also have multiple chronic conditions. And of course, vice versa. The people with chronic health conditions are at the higher risk. People who fall with ADRD have a much more difficult time with their recovery and the complications as a result of that. With the Arizona Department of Health Services priorities, again, I mentioned that we figured that although research is important, and we are and we have been focused on the public awareness messages, the most impact that we can make is on the caregivers' support. So in public health, as you know, in our department, we are always aiming for high population impact, scalability, and sustainability. We do promote evidence-based programs or promising practices that can be evidence-informed. and we look at sustainability through policy and systems change to ensure and support a collective impact. What we did was, in this first step of our assessment, we identified some key funders, and this is a very innovative approach in that we joined private-public partnerships with Arizona Department of Health Services and Maricopa County Department of Public Health, Maricopa County being one of our largest counties in Arizona, 5th largest in the country, and with Virginia G. Piper Charitable Trust and Vitalis Health Foundation, who are the two funders in the Maricopa County area, to look at what the needs are and how we can incentivize the partners in the community coming together to collectively apply for funding that would help us with the intended goal, which I will share with you. The second step was to identify some common grounds and, again, making sure that what we develop is scalable and sustainable. Again, the whole is greater than some of its parts. Therefore, we wanted to work with our funding partners to help break down the silos. And we looked at our history with our relationships and how we can best be productive with those relationships in the community. The third step was to identify some key providers in the community, and I have listed those partners initially in the Maricopa County, some of whom their service reach catchment areas or reach beyond some of the Phoenix greater metropolitan area and out of Maricopa County. But these are the partners who are currently engaged with us, and the step 4 was to conduct that social network analysis that was commissioned through the University of Colorado, Denver. So we looked at the services provided, gaps in services, types of interactions, the resources, and the trust between these relationships, the quality and content of the relationships, and I had shared with you what the questions were that we had asked. So the fifth step was for us to convene key partner providers to share the survey results. We discussed the recommendations that I will share with you shortly, and then we determined the interest in closing the gaps, or determined the interest of our partners in closing the gaps in services to caregivers. So we looked at how the agencies were working together and in terms of their awareness, their level of cooperation, coordination, and integration of services. And these are the following are the recommendations based on that network analysis. The recommendation was to develop protocols and support for joint service delivery. So based on the fact that agencies appear to maintain primarily low resource-intensive types of relationships, and the assessment also showed us that they were developing support for these we needed to develop support for these kind of activities that could be and that would be a role for stewards of the network, which we now call the caregiver group or caregiver coordination group. And we again looked at developing innovative funding models while maintaining standards necessary to support these services by identifying the regions and the gaps in the services that we need to fill. And a deeper understanding of the misalignment of the efforts with success was identified as being important in order to adequately leverage the resources in the system. So we're we are currently working on aligning the services with quality of delivery, and what we have, it's an ongoing process with our partners to basically develop an alliance for these services among the partners. So we also, another recommendation was to identify a neutral convener or a hub for bringing the partners together and coordinating the interactions between all these partners based on the identified gaps. And the Department of Health Services was unanimously selected by the partners as a neutral convener, which it speaks highly for our relationships in the community with our partners. And there was, as I said, consensus among stakeholders at the interactive session that we held in person with our partners and the leaders in our community to work towards a shared vision and create and formalize a statewide network to serve as a community of practice. So the sixth step in our needs assessment, if you will, was to conduct a follow-up phone survey, and then the phone survey was based on several key questions that were developed jointly. And okay, so now my slides are, my apologies, my slides are advancing below, but it's not advancing on the screen. Do you see them advancing? Because I cannot see them advancing.
Are you now able to see interview results slide, Dr. Nayar?
Okay, now I see it on now I can see it on mine. It took, there was a gap, and then it showed that there was a lost connection, and then it reconnected. My apologies for that. So the interview results, based on the phone interview results, were collected and integrated. So there were concerns that agencies would, whether agencies would play nice or continue to compete in silos. People were talking about sharing problems through a neutral convener to ensure transparency, and of course for us to help with the vision setting, and by us meaning the statewide convener, in our case the Department of Health Services. And our focus is, as part of the vision setting, is to create a single entry 24/7 helpline, and as part of that no wrong door approach, where caregivers would have access to a single platform to identify and reach for services that they need. And for us to move from a perspective or eyes of the lens of competition to collaboration, and then for us to rally around population health outcomes. There are scope of formal partnerships was to develop formal partnerships with our Dementia Caregiver Alliance partners, and to draft an action plan, which we are currently working on. And then we will also keep the momentum going by keeping really close and tight timelines for this process, so that people can continue to be engaged and not lose interest. Now we will be reconvening. We reconvened a group just to have a reality check point, and we will continue to have other group meetings with our partners to look at the statewide Dementia Caregiver Alliance that will be created and is currently, again, in process of being created. And there will be a the goal being that there will be a statewide single entry helpline. And some of these things I've already reviewed, but the partners, the public-private partnership has made a commitment for 5 years to leverage resources, and that's between the Arizona Department of Health Services, Maricopa County Public Health, and our two private funding foundations, both Virginia Piper and the Vitalist Health Foundation.
Hi, Dr. Nayar.
Yes.
Apologies. Would you be able to wrap up in 1 minute? So we have a few minutes.
So we have one more slide, and we will wrap up. So the final step and plans were to identify and convene representatives from the work groups, and we have identified key leaders from each partner, community partner, to participate in the alliance and participate and contribute to the leadership group. So we will be publishing a calendar of alliance meetings, and the next step would be the execution of the plan. So that's where we're at in terms of our needs assessment, and I think this has been a wonderful exercise for us. I can't emphasize enough the need for resources for caregivers, and we are also implementing the Public Health 101 curricula that was developed by the Alzheimer's Association in creating programs or training programs for our certified public or certified peace officers, as well as EMS, the Emergency Medical Services. With that, I thank you, and I'll turn it back to you.
Thank you, Dr. Nayar, for your presentation, and apologies for the typo on your credentials. We'll be sure to update the slides before sharing them with meeting attendees. I think we have time for about 1 or 2 questions, so if everyone can chat in their questions if they have any. In the meantime, I do have a question for Dr. Nayar and Ms. Rice. So you both had very different focuses for and approaches to doing needs assessments, yet both generated insights that were critical. What difference did the results of your needs assessment have on your state's responses to Alzheimer's and dementia caregiving? So if either one of you can give us a response before wrapping up.
This is Michelle. I can take that first. Because we at the North Carolina Institute of Medicine do these sorts of similar assessments and development of plans for a lot of different health issues, we always find that when we have a mandate from our legislators, that's certainly an easier way to get attention to the recommendations that come out of the task force, whether that's, because there's a reporting mechanism already built into the mandate, or just the push for the work at the beginning helps to make sure that there is a push for the implementation of the recommendations that come out of it. So I would say that. I didn't really talk about our communications plan in my slides earlier, but we did work pretty closely with several of our partners, particularly in the advocacy community, both with the Alzheimer's Association and with AARP, around developing a lot of different strategies around press coverage, around making sure that we had a social media kit that went out with the release of the report, and wanting to get attention really across the spectrum to the recommendations. So I think that helped a lot in terms of getting the early sorts of momentum for the results of the needs assessment.
Thank you so much, Michelle, for that response. We're now close to the top of the hour. As we wrap up, I would like to let you know that you will automatically be directed to a survey at the conclusion of this webinar. Please take a few minutes to complete the survey, as it provides us with useful information for our future webinars. This concludes today's webinar. ASTHO and the Alzheimer's Association would like to thank all of today's speakers and participants. A recording of today's webinar along with the presentation slides will be sent to your email within 2 to 3 days. If you have any follow-up questions about today's webinar, please feel free to contact the teams at ASTHO and the Alzheimer's Association using the emails addressed on your screen. Thank you, and hope you have a great rest of your day.
Thank you.
Thank you very much.
Thank you.